So, a 65-year-old man walks into the emergency department. Well, actually, he doesn't walk.
Right, he can't. He's violently dizzy.
Exactly. He's been dizzy for 6 hours. He's vomiting. And he literally cannot stand up or walk unassisted. So the clinical team, they start the standard workup. Blood work is totally normal.
Yeah, and then they send him to the scanner.
Right. They do an early non-contrast CT of the brain, and it comes back perfectly clean. I mean, no bleed, no obvious masses, nothing.
Which, unfortunately, gives everyone a massive false sense of security.
Totally. The team feels reassured, so they discharge him with a diagnosis of peripheral vertigo. But then 48 hours later, that exact same 65-year-old man comes back to the hospital with a massive, life-altering posterior circulation stroke.
And, I mean, the absolute tragedy of that specific case isn't that his anatomy was just impossible to figure out. The tragedy is that all the clues were right there at the bedside. They were just missed because of this fundamental misunderstanding of what our diagnostic tech can actually do in the acute setting.
Right. Which brings us to today's topic. Welcome to this deep dive. Our mission today is to dissect exactly what went wrong in this case and to arm you, whether you're a medical student, a resident, or, a frontline clinician, with a really practical, safety-focused approach to the dizzy patient.
Because the ultimate goal here is simple, right? Never miss a posterior circulation stroke while still confidently managing all the benign causes of dizziness.
Exactly. And to do that, I think we really need to start by looking at the imaging. Because we tend to treat a clean CT scan like a get-out-of-jail-free card. But in reality, it's just a highly specific tool doing a very specific job.
Yeah, that's a perfect way to phrase it. The non-contrast CT scan in the acute setting has one job, and that job is finding acute hemorrhage. It's looking for bleeding.
Just bleeding, not a stroke.
Right. And that is the fatal flaw in modern triage, assuming a normal CT rules out an ischemic stroke. In the first 24 to 48 hours, early non-contrast CT scans are basically blind to early ischemic strokes in the posterior fossa.
Wait, hold on. We have these million-dollar diagnostic machines, and you're telling me a doctor's eyes and hands at the bedside are actually more sensitive in the first 24 hours?
Oh, absolutely. 100%. It comes down to biology and physics. When tissue is ischemic, meaning a clot is starving it of oxygen, it doesn't instantly change density.
Right, because the cells are just starting to die.
Exactly. It takes time for that starving tissue to swell and develop edema. And that edema is what eventually shows up as a dark spot on a CT scan, but like days later.
Wow, okay, so the scan is just too early to see the damage.
Yeah, and beyond the biology, you have the physical limits of the scanner. The posterior fossa, which houses the brainstem and cerebellum, is surrounded by the densest bone in the entire body.
Oh, at the base of the skull, right.
Yeah. And that dense bone creates what we call beam hardening artifacts. The X-rays from the CT scatter when they hit it, creating these streaks across the image that completely hide the delicate tissue of the brainstem.
Okay, so the rule you really have to burn into your memory here is this. An early CT scan rules out hemorrhage. It does not rule out an ischemic stroke.
A normal CT absolutely does not equal no stroke. Full stop.
Right. Which means, since the CT scanner can't save us, we need a clinical roadmap. How do we actually navigate a symptom as vague as dizziness at the bedside?
Well, the first step is we have to stop asking the patient, what does your dizziness feel like?
Oh, totally. Because that leads to the most unreliable history ever. 1 minute they say it's spinning, then it's lightheaded, then they just feel woozy.
Exactly. It's way too subjective. Instead, we have to look at the mechanics. We use a framework called the titrate classification.
Titrate, which stands for timing and triggers, right?
Right. You divide every single dizzy patient into two main branches based purely on how long the dizziness lasts and what specific mechanical actions bring it on.
It's like troubleshooting a broken car.
Yeah.
You don't just ask the driver what the bad noise sounds like because they'll say it goes clonk or whoosh, which is useless.
Yeah, that tells you nothing.
Right. You ask the mechanical questions like, does the engine sputter all the time, which is continuous, or only when you turn the steering wheel to the left, which is triggered?
That is a great analogy. So branch 1 is continuous dizziness. This lasts for hours or days with no specific trigger. It's just spontaneous. We call this acute vestibular syndrome, or AVS.
Okay, continuous is AVS, and branch 2.
Branch 2 is episodic, triggered vertigo. Brief spells, lasting seconds to maybe a minute, brought on by a specific movement like rolling over in bed.
Got it. So let's follow that first branch, the continuous AVS patients. This is where the high stakes are, right?
Very high stakes. You're trying to differentiate between vestibular neuritis, which is just benign viral inflammation, and a posterior circulation stroke, which is deadly.
And since we can't trust the early CT scan, how do we tell them apart?
Enter the HINS exam. It is an incredible bedside tool. But, and this is crucial, there is an absolute golden rule for when to use it.
Let me guess. You don't just do it on everyone who says they are dizzy.
Definitely not. You only use the HINS exam on patients with continuous dizziness AVS who currently have spontaneous nystagmus, meaning their eyes are actively jerking while they just sit there looking at you.
What happens if you do it on someone with brief positional vertigo or someone who isn't currently dizzy?
It's super dangerous. You will get false central signs. You'll see an abnormality and think they're having a massive stroke when their brain is completely fine.
Oh, well. Okay, so AVS with spontaneous nystagmus only. What does HINS actually stand for?
Head impulse, nystagmus, and test of skew. Let's start with head impulse. You ask the patient to stare directly at your nose, and you rapidly but gently turn their head about 10 to 20 degrees to one side.
We're testing that reflex, right? The vestibulo-ocular reflex.
Right. When your head turns left, your inner ear tells your eye muscles to move your eyes right at the exact same speed, keeping them locked on the target.
But if the inner ear is inflamed, like with vestibular neuritis, that signal is broken.
Exactly. So when you turn their head toward that bad ear, the reflex fails. Their eyes get dragged along with the head, and they briefly lose sight of your nose.
And then the brain realizes the mistake and consciously snaps the eyes back to your nose.
Yes. That visible snap is called a corrective saccade.
Okay, just to be clear, if their eyes completely fail to stay locked on my nose and have to visibly jump back to correct themselves, that's actually the good news.
It sounds totally counterintuitive, but yes, that corrective saccade means the hardware in the inner ear is broken. It's a peripheral problem. It's reassuring.
Wow. Okay, so what's the terrifying scenario then?
The terrifying scenario is a dizzy, vomiting patient. You rapidly turn their head, and their eyes stay perfectly, smoothly locked on your nose. No correction at all.
Because that means the inner ear is working perfectly fine.
Exactly. Which means their severe dizziness is coming from deeper inside the brainstem. No correction equals central. It's a stroke until proven otherwise.
That is wild. Okay, so that's the head impulse. What about the N in HINS? Nystagmus.
We look at the involuntary beating of their eyes. If the fast beat always jerks in the exact same direction, no matter which way they look, that's unidirectional. It's usually peripheral.
But if it changes direction?
Direction-changing nystagmus, like beating right when looking right, then beating left when looking left, that's a central sign.
Right.
Brainstem processing failure, stroke.
Got it. And finally, the test of skew.
This tests vertical alignment. It's a simple cover-uncover test. Cover one eye for a few seconds, then uncover it. If that eye drifted vertically and has to shift up or down to realign, that vertical correction is a central sign.
Because an inner ear problem almost never causes pure vertical misalignment, right?
Exactly. It's almost always a disruption in the gravity-sensing pathways in the brainstem. And here is the ultimate rule for HINS. Any one central sign equals stroke until proven otherwise.
Just one. So if the head impulse looks peripheral and reassuring, but they have a vertical skew...
You treat it as a stroke. Do not pass go.
Okay, but this HINS exam requires a really sophisticated look into the patient's eyes. If we rewind to that 65-year-old man from our opening case, he had a massive red flag that required no eye exam skills at all.
Yeah, he had the most glaring central sign possible. He couldn't stand, he couldn't walk.
Which we forget to check, right? We get so hyper-focused on cranial nerves and the nystagmus that we literally forget to look at the patient's feet.
We do. And we really can't skip the physical mechanics of balance. The cerebellar exam is the fifth vital sign in the dizzy patient. And the single most critical metric is the gait assessment.
So what's the hard rule here?
Severe gait disturbance in a dizzy patient is stroke until proven otherwise. If they cannot walk independently or sit upright on the edge of the bed without support, treat as stroke. Full stop.
Man. So the tragedy of that opening case is that they discharged a guy who couldn't stand up just because his CT was normal.
Right. He didn't need $1 million scan to show his brainstem was dying. His lack of truncal balance was screaming the diagnosis.
Examine before you image. Okay, so we've covered the dangerous continuous AVS branch. But what if our titrate roadmap points us down the other branch?
The episodic triggered branch.
Yeah, The patient who feels perfectly fine until they roll over in bed, and then the room just violently spins for like 15 seconds.
That points directly to BPPV, benign paroxysmal positional vertigo. It's a pure plumbing problem in the inner ear.
This is what patients call ear rocks, right?
Exactly. We all have these microscopic calcium crystals called otoconia in a sac called the utricle. Sometimes, due to age or trauma, they break loose and float into the semicircular canals.
And those canals are only designed to detect rotational movement, not gravity.
Right. So when the patient lies down, gravity pulls those heavy crystals through the canal fluid. It creates drag, bends the sensors, and sends a massive false signal to the brain that they are violently spinning.
Even though they are lying totally still. That sounds terrifying.
It is. But it only lasts a few seconds until the crystals settle. Because it's mechanically triggered by head position, we diagnose it with positional testing. We do not use the Hintz exam here.
Right, because Hintz is only for continuous dizziness. So what test do we use for BPPV?
For posterior canal BPPV, which is most common, we use the Dix-Hallpike test. You sit them up, turn the head 45 degrees, and rapidly lay them back so their head hangs slightly off the bed.
And what are we looking for in their eyes?
Torsional upbeating nystagmus. The eyes will literally twist and beat upwards toward their forehead. It lasts less than a minute. If you see that, you've confirmed it.
What if the Dix-Hallpike is negative, but they definitely have these brief triggered episodes?
The crystals might be in the horizontal canal instead. So you do this supine roll test. Have them lie flat and rapidly turn their head 90 degrees to one side, looking for horizontal nystagmus.
Okay, so once we know where the crystals are, how do we treat it? I mean, we treat the mechanics, right? Not the symptoms.
Exactly. We use repositioning maneuvers. For the posterior canal, the first-line treatment is the Epley maneuver. You're basically rolling the patient's head through a series of angles to physically dump the crystals back where they belong.
Like rolling a marble through a curved plastic tube.
Exactly like that. And if it's the horizontal canal, you use the barbecue roll or the Guffoni maneuvers.
Which brings us to a huge pitfall, right? Because the first instinct for a lot of clinicians when they see a nauseous, dizzy patient is to just order a scan and write a prescription.
Yes, and that is a massive mistake. Routine imaging is absolutely not required for typical BPPV. A CT scan of the brain shows you zero information about microscopic crystals in ear fluid.
And the medications might actually be worse.
Oh, vestibular suppressants like meclizine or benzodiazepines, they should be minimized or completely avoided for BPPV.
It's like giving vestibular suppressants for BPPV is like turning down the volume on your house's smoke alarm instead of actually putting out the grease fire in the kitchen.
That is perfectly said. The alarm is annoying, but suppressing it doesn't fix the fire. You have to do the Epley maneuver. Plus, these BPPV spells only last 20 seconds. By the time the pill kicks in, the vertigo is already over.
And now they're just super groggy.
Exactly. It dulls the brain's ability to compensate, delays recovery, and makes them a massive fall risk. Treat the mechanics. Don't use chemical suppression.
Man, we have covered a ton of ground today. Let's do a rapid-fire summary. This is the never forget list for you listening out there. Number 1, timing and triggers.
Right. Timing and triggers guide 80% of the diagnosis. Discard subjective descriptions. Figure out if it's continuous or triggered.
Number 2, continuous dizziness means do Hintz.
But only if they have spontaneous nystagmus. And remember, any one central sign means stroke until proven otherwise.
Number 3, inability to walk.
Is a stroke until proven otherwise. Severe gait disturbance is a massive red flag.
Number 4, the CT trap.
A normal early non-contrast CT does not rule out a posterior stroke. It only rules out bleeding.
Number 5, examine before you image.
Your clinical skills, titrate, Hintz, gait assessment are way more powerful than an early scanner.
And number 6, when in doubt.
Treat as a stroke.
Absolutely. So let's bring it back to that 65-year-old man from the beginning. The tragedy wasn't that his CT scan failed him right. It did exactly what it was supposed to do. It proved he wasn't bleeding.
Exactly. The failure was that nobody watched him try to walk. He didn't need more million-dollar tests. He needed a proper bedside exam.
Yeah. Your clinical skills really are more powerful than your scanners in these acute moments.
They are. You just have to trust them.
Totally. Well, we want to leave you with a final kind of provocative thought to mull over on your own. We talked about how routine vestibular suppressants like meclizine are basically useless for fixing BPPV. right?
Right.
And how they make patients groggy.
Right.
But think about the broader implications for our exams. If these medications actually suppress the very nystagmus and eye movements that we rely on.
Oh, to perform the Henson-Dix-Hallpike exam?
Exactly. Are we inadvertently blinding our own clinical exams? Like, are we actively sabotaging our best diagnostic tools and increasing our patients' fall risks just to stop them from complaining about nausea so we can clear an ED bed faster?
That is a scary thought, but a really important one.
Something to really think about the next time you instinctively reach for that prescription pad. Thanks for joining us on this deep dive. We'll catch you next time.